undergraduate at Columbia University, studying neuroscience on the pre-med track, and I am part of Columbia Synapse's peer support group.
Hi, my name is Jessica. I'm also an undergraduate student at Columbia College. I'm a rising sophomore and I'm hoping to major in neuroscience and behaviors. And I am part of the peer support meeting and I'm one of the officers within that group.
My name is Wyatt. I am a pre-med postdoc at Columbia. Um, I'm on the peer support team, and then also I was in the storybook team. Uh, and yeah, I suffered a moderate TBI um, many years ago now. So it's an honor to uh, be back. And I actually I was hospitalized at Bellevue, so it's nice kind of to connect uh, on this level with all of you.
Awesome. And so just to provide a little bit of introduction as to who we are. So Columbia Synapse is a student organization at Columbia, and we're dedicated to providing support and advocacy for brain injury survivors. And so at the core of our work is our weekly virtual support group meetings, where volunteers like us and survivors with traumatic brain injury come together in a supportive space weekly every Saturday from 2 to 3 p.m. And this is a really safe space where individuals can share their experiences, navigate challenges, and offer emotional support and resources to one another. And a lot of the participants have really benefited from these weekly support gatherings, as one of the main hurdles and challenges of having a brain injury is the sense of isolation and not being able to branch out or find other individuals who are able to empathetically understand their perspective and where they're coming from. So through reflective discussions where we host themes like identity, resilience, gratitude, and adapting to new realities, we aim to empower survivors with both practical strategies and a strong support network. But beyond just our weekly support group meetings, a large part of what we do is advocacy and education. And we hope to take the experiences and the challenges that we hear from our participants into tangible action. And we've done this through raising awareness through different educational outreach initiatives like this one. And we hope to bridge the gap between medical knowledge and the lived experience and ensure that survivors' voices are heard in research, policy, and community discussions. One of the major initiatives that we've been working in the past year is our storybook project. So through this project, our peer support group committee collaborated together that's dedicated to honoring and amplifying the voices of individuals and caregivers living with traumatic brain injuries. So many of the individuals that we spoke to described the feeling of being invisible and misunderstood, and that they have a feeling of being trapped between the desire to be seen in a world unprepared to understand them. So what increasingly became clear to us was how wide the gap was between the public's understanding of brain injury and the reality of living with them. So through their words, we found the opportunity to bring these stories to light as a catalyst for change. And when we first proposed this idea to the participants, many of them were super enthusiastic to share their stories and were just looking for opportunities in order to have their voices amplified. So, with this in mind, we brought together our committee and we conducted in-depth interviews over the past semester and integrated compassionate storytelling to present some very powerful and moving stories within this compiled storybook. And as you can see in some of the images, we even included some artwork from some of our participants as well as artwork from our own committee. And within our the storybook as well, we included supplemental pages with more informative pages like a brain injury myth versus fact, as well as a QR code with a compiled list of resources at the end that we're hoping that survivors and caregivers can use and to also take away from the storybook a sense of community belonging and the feeling of being heard. So our presentation today is largely based on quotes and material drawn out from our storybook that we hope to integrate within factual information as well. And so through this, we hope to shed light on the emotional and humanistic aspect of having a brain injury beyond just the clinical manifestations. So one of the questions that we asked all of our participants in our interview was, what was your healthcare experience like? And what do you wish that healthcare providers knew about? So to ground our discussion today and the importance of this presentation, we wanted to start off with just introducing a few of those testimonials. So one of our participants mentioned that, quote unquote, the medical community doesn't actually address the type of pain we suffer from. It's not a migraine, yet they treat it as if it were a migraine. They give us these things but it doesn't work, and we don't have the words to describe the pain. And by the time we're at a location, we can't describe it either because we're in so much pain and we can't talk about it, or we may have aphasia. Another participant commented that the thing I saw that needs improvement is that when you have an invisible injury, it's very easy for modern medicine to immediately go down a mental health road. That is probably part of it when you have an invisible injury. Another thing that I witnessed was I felt that as a female reporting a bunch of physical symptoms, it was very easy to jump to this. I left the military with a PTSD diagnosis, even though I didn't have a specific trauma. They had this idea that women are emotional, and there's data out there that reports women are almost twice as likely to leave their first doctor's appointment with a mental health diagnosis. I think these sorts of issues and the idea of treating symptoms with medicine, as opposed to looking for the underlying cause and really addressing it, needs to change. So, as some of these quotes highlight, while there's no doubt that healthcare presenters and you all are committed to doing what's best for the patients, there still remains a real and persistent gap between the medical system's intentions and the lived experience of brain injury survivors. And as we'll point out throughout our presentation, several other factors dealing with emotional and social difficulties that go beyond just the physical challenges accompanying a brain injury further complicate the healthcare experience. With that in mind, I want to share 3 main goals from today's presentation. First, we aim to share the voices and stories of TBI survivors. Their lived experiences are powerful, and presenting them in an empathetic and authentic way helps build awareness and fosters a deeper understanding of what it means to live with a brain injury. Second, we will highlight the key challenges that survivors face, particularly when interacting with the healthcare system. This includes issues related to accessibility, communication barriers, and lack of long-term support. And third, we want this to be a collaborative effort. As healthcare professionals or aspiring physicians, your role is pivotal, and we'll discuss ways we can work together to build a more responsive, accommodating, and patient-centered environments that don't just treat the symptoms, but support the whole person, especially patients navigating life after the brain injury. So these goals will ground our discussion today, and we hope that they'll spark thoughtful dialogue as well. We'll start off first by highlighting key challenges that survivors face, and then transition to some takeaways, and finally some actionable items and resources that you can use as well. But before we get started with any of the actual content, we wanted to just start off with a little brief art exercise. As one of the most powerful things we've learned in our conversation with the survivors is that the experience of a traumatic brain injury isn't always easy to articulate in words. The sensations, confusion, fatigue, and emotional shifts can be overwhelming and often difficult to explain to providers. And that's where creative expression really becomes viable. So as you can see on the slide here, these are 2 paintings actually from our own participant called Betsy, and she titles them Painting of How My Brain Felt to Me 4 Days After Mild Concussion. So if we can take maybe just 5 to 6 minutes, if you won't mind, that I'll guide you through a mini art reflective exercise. So I'm going to give you all just at least 1 minute to just quietly observe the artwork, take in the textures, colors, the movement, and resist to the urge to label or analyze and simply just observe. So I'll give you all 1 minute to just do that. Okay, and now that you've hopefully had a few minutes to just take in the artwork, so since this isn't Zoom, I'm not entirely sure if there still is a chat feature, but if anyone would like to also unmute, or if there is a chat feature, put in the chat some of your thoughts. So we have a few questions that you can maybe think of. So first is, sorry, just what emotions or sensations does this artwork evoke in you? What do you notice about texture, color, and maybe the contrast between the chaos versus order? And what does this piece reveal that clinical tests might not? How do we currently respond to patients when their suffering isn't outwardly visible? In what ways are our care systems equipped or unequipped to respond to this kind of internal experience? And what would it mean to take this seriously as clinical data, not in the literal sense, but in how we attune to patients' realities? So, yeah, if anyone would like to unmute, maybe put in their chat their thoughts or any other ideas that come in mind when they take a look at these two paintings.
Hi, can you guys hear me?
Yes.
I think it definitely feels a little bit sort of chaotic or maybe disorganized, being pulled in different directions, especially with on the picture on the left, like there's two different halves. So maybe they're feeling like divided in some way. And I think to your other question, maybe sort of about how we can like interpret this in being on the kind of medical side of things, I think it really resonates where you're saying they were sort of trying to be like fit into a certain bucket, like you have migraines, even though that's not what they're experiencing, and maybe just being okay with not having a perfect diagnosis to label it and using tools like this instead as a way to see how the progression or improvement is happening.
Yeah, thank you so much for sharing your thoughts. That was really insightful as well. I think I heard someone else try to unmute. Yeah, from our presentation from last time as well, someone had commented on like the right word painting with like the green. It kind of looked like, I don't know, like kind of exploring a forest in some way, or that sensation of both like not really knowing where you're going, but there's also still room for growth, or at least trying to find the beauty within this kind of like clustered chaos. So I think after a presentation as well, if you want to maybe just keep these two pieces in mind and maybe even think about like how your interpretation even changes over the course of it. So thank you all for participating in this mini exercise. And with that, I'll hand it off to David to talk a bit about the BPSE model.
Thank you, Claire. So this is a figure of the BPSE model, which highlights that recovery is shaped by biological, psychological, social, and environmental factors, which is a framework that looks at the whole person. So biological factors like genetics and immune response interact with psychological factors like grief and anxiety, social supports like family and peer groups, and environmental systems like healthcare access and public policy. This model is an effective starting point to help us bridge the gap and learn to adopt a holistic lens to bridge the gap between what survivors need and what systems currently provide. So through our interviews and ongoing conversations with members of our peer support group, we've learned that many of the greatest challenges survivors face are invisible and internal. Cognitive and emotional symptoms often disrupt not only daily tasks, but also patients' sense of identity. Many struggle silently with memory lapses, confusion, and an overwhelming sense of mental fog. They may feel increasingly isolated, both socially and emotionally, and grieve the person they were before the injury. One of the hardest challenges that survivors express is operating in a world that expects them to act a certain way when their invisible disabilities prevent them from doing so, often resulting in feelings of isolation. Communication challenges also stand out as one of the biggest barriers for TBI survivors. Many survivors struggle to express their pain or needs due to aphasia or cognitive difficulties from the injury, which leads to feelings of frustration, isolation, or even acting out, not because they want to, but because they can't find the words. One survivor said, if you sit and try to remember that word and you sit there and you just get frustrated and angry because you can't articulate it, that's why most TBI people act out, because we can't communicate. So survivors often describe how their thoughts feel scattered. And one of the less obvious but still deeply relevant and impactful challenges after TBI is the tendency to go off on tangents, like they're trying to follow a thread that keeps unraveling. They may begin answering a question and then veer off into unrelated topics. Many of them, even in our support groups, sometimes need reminders of where they left off in a train of thought. This is compounded by a second major challenge, emotional regulation. When someone knows what they want to say but can't find the words, especially when the stakes of a conversation are high, like in a medical setting, frustration builds quickly. This is compounded on the fact that many TBI individuals have difficulty regulating their emotional responses because of damage to areas of the brain involved in impulse control, frustration tolerance, and self-soothing. As providers, recognizing these invisible barriers means we have to shift how we listen. It may mean slowing down, offering alternative modes of communication, or simply giving someone the time and space to find their words. Moreover, it's very important to resist the urge to label these patients as difficult, non-compliant, or aggressive too quickly. Many of our support group members have shared stories and praise of physicians who have demonstrated incredible patience with them, serving as a source of hope to them in an otherwise difficult system for TBI survivors. Traumatic brain injury often results in a complex interplay of cognitive and physical impairments that can profoundly impact an individual's daily life. Some things survivors frequently experience are memory impairments, including difficulties with short-term memory, attention, and information processing, which can manifest as forgetfulness, confusion, and challenges in learning new information. One patient said how it was just gut-wrenching to see and notice the errors, because this is the A chick, the one who didn't have to study, and all of a sudden she couldn't put a sentence together. She couldn't pick up a bottle of hand soap because she couldn't remember the word hand soap. They also have difficulties with executive functioning. TBI can impair planning, problem solving, and multitasking abilities, leading to challenges in organizing daily activities and making decisions. These are compounded by motor control issues. Physical symptoms of these could be poor coordination, balance problems, and fine motor skill difficulties, which can lead to trouble with simple things like writing or buttoning clothes. They can see the quote here, dexterity is a big issue every single day, I would say almost every hour. These challenges are not only physically and cognitively taxing, but also emotionally impactful, as individuals are forced to navigate the loss of their previous abilities and adapt to these new limitations. Many survivors in our storybook emphasize the importance of holistic, individualized care. As survivor Imani powerfully put it, everybody's experience is different, the same way our thumbprints are different. This points to the need for precision and personalization in treatment. Currently, the field lacks universally accepted definitions and criteria for TBI. For example, the Glasgow Coma Scale, which is widely used to assess TBI severity, is imprecise and can introduce care biases. There are as many 38 overlapping definitions of mild TBI, which creates confusion and inconsistency in how patients are diagnosed and treated. This complexity makes it difficult for survivors to get the tailored care they need. In our support groups, no two survivors shared the exact same diagnosis, symptom profile, or post-injury challenges. Many had underlying medical conditions such as migraine, autoimmune disorders, or mental health diagnoses that further complicated their recovery and blurred the lines between TBI-related symptoms and other ongoing health concerns. This attests to the need to understand brain injury as existing on a spectrum rather than static categories. And just as the diagnosis of a brain injury often isn't uniform, treatment should be adjusted as such. Vivian, another participant, stressed the importance of a holistic approach, noting that physically, her brain learned proprioception more from yoga than all of the PT. Her experience highlights that recovery isn't just about standard therapies. It's about integrating complementary strategies that fit the unique needs of the patient. A holistic approach is one that can be adapted to the specific needs and goals of a patient in a way that can change over time. Creative approaches are employed using that BPSC model to assess the various psychosocial aspects of a patient that may have been affected by the injury and may work together as they recover. For Vivian, yoga played an important role in her unique recovery process, serving as an example of something that can be adapted to a patient's abilities and goals. She was able to engage with it in ways that suited her, ultimately noticing the physical, psychological, and emotional benefits reinforcing each other. And so with that, I'll pass it on to Raga.
Back to Imani, she was an individual who prided herself on her brain, a gifted, self-described straight-A child. Her main passion was giving back to the community, including finding success in property management as the woman to call for the most difficult renovation jobs. After losing a child, she gave back by teaching people financial literacy to save up for homes. Being rear-ended by a truck and acquiring a TBI from the incident completely overturned Imani's self-perception. In this quote, she mentions it's like a magician's trick where they take the tablecloth and snatch everything. This quote underscores the profound psychological impact of TBI as a disruption of self. For Imani, intellectual ability was a core part of her identity. When that cognitive capacity was lost, It wasn't just about struggling with tasks like memory or concentration. It was about experiencing a collapse of who she believed herself to be. This is why it's essential for providers to not only understand the symptoms a patient presents with, but also what kind of life they're returning to or no longer able to return to. The trauma isn't always the injury itself, it's the sudden disorienting shift from independence to dependence, from clarity to fog, from confidence to doubt. Even when the body looks intact, the patient may feel unrecognizable to themselves. These reflections are also a reminder that background matters. Patients who once identified strongly with mental agility, physical strength, or communication fluency may experience more acute psychological fallout when those traits are disrupted. A one-size-fits-all approach to rehab won't address this. Care needs to be attuned to identity loss, emotional processing, and the grieving of former selves. As clinicians and healthcare leaders, it's important to treat not just the brain, but the person whose life has been reshaped by that brain injury. Carmel is a vibrant and multi-talented individual whose identity was deeply rooted in her creativity, ambition, and independence. She described herself to be really high functioning, as she was juggling two businesses, two jobs, and a thriving artistic practice. She found joy in reading medical books for fun and expressed herself through sculpture and photography. Her life was filled with movement, purpose, and passion. Just before her injury, she was in Los Angeles organizing a major art exhibit. She had been working on a documentary photographing the gay community and regularly attended Pride events, capturing moments of celebration and resilience. Her life was fast paced and meaningful, and then everything changed. This quote powerfully captures the identity crisis that can occur after a TBI. For Carmel, the sudden shift meant questioning who she was without her work, her art, her constant motion. What happens when you aren't really the person you were? Is an identity crisis many survivors face. It's not just about physical or cognitive symptoms, it's about grieving a former self and finding a way to rebuild identity in the aftermath. We also need to recognize that TBI affects all individuals differently, as demographics and social context significantly shape recovery. Systemic inequities matter. At the patient and family level, outcomes are influenced by factors like race, ethnicity, socioeconomic status, and access to community resources. Providers must undergo cultural competency training that is specific to the diverse needs of the TBI population, recognizing how pre-injury resilience, cultural beliefs, and social supports affect recovery. Gender differences are especially significant. Women often experience worse symptoms after TBI, partly because they are underrepresented in research and clinical trials, especially in cases related to intimate partner violence. Women who seek medical attention for brain injuries are 7.5 times more likely to be survivors of domestic violence compared to women with other injuries. This means that recovery is not just a medical process, but one shaped by gendered social expectations and access to appropriate services. Age also plays an important role. For younger individuals, sustaining a TBI can drastically reshape their social and emotional lives. They may lose the ability to participate in activities that define their identity, such as athletics, and may need support in constructing new identities and social roles. Additionally, the ICF framework was published by the World Health Organization in 2001 to help shift focus from not only diagnosis, but also to function by asking questions like, how does this condition affect your daily life, rather than just what's happening with you? This mirrors what TBI survivors have emphasized, the need for holistic, individualized care. ICF highlights how health conditions interact with three main domains: body functions and structures, activity, and participation. This explains why two people with the same injury may have vastly different outcomes. To support TBI survivors, it's crucial to look beyond just the injury and address environmental factors, social support, and individual strengths so patients can fully participate in their daily life activities. Living in a rent-stabilized room in Manhattan, Eric has faced accusations from his landlord and attorney. They think he's trying to take advantage of them. In reality, Eric struggles with symptoms of his TBI and finds himself unable to properly stand up for himself and be truly understood. Even when he explains that he may need additional time to process or understand, he finds himself repeatedly disregarded and exploited. No matter how hard he tries, he can't always hold up accountable for their actions. The high cost of long-term rehabilitation and support services may prevent many TBI survivors from receiving the care they need. This issue is especially significant when survivors are unable to work due to their symptoms, which can further limit their access to necessary medical support.
We must also address the system-level barriers to effective care. The current healthcare system for TBI is often episodic and fragmented. Survivors typically experience multiple handoffs between acute care, rehabilitation, outpatient services, and community organizations. And these constant transitions create opportunities for mistakes, oversights, or for the patients to fall through the cracks. Many survivors report a lack of help navigating the maze of specialized, often obscure services, which leads to delays or even abandonment of needed care. A major structural challenge is that conventional approaches to data analysis fail to capture the multivariate, complex nature of TBI, reinforcing the need for research and care systems that handle nuance and variability, rather than forcing survivors in a rigid, one-size-fits-all approach. Moreover, isolation and the feeling of FOMO, or the fear of missing out, is a prominent issue that a lot of traumatic brain injury survivors can face. Multiple studies support social interaction and the presence of loved ones as factors for improving patient outcome. When an injury fundamentally alters the way that an individual perceives reality or engages with others, that supportive network can become more tenuous. What makes this especially hard is that TBI is often an invisible disability. The person may look exactly the same as they did before the injury, but inside they may have navigated sensory overload, cognitive fatigue, or emotional dysregulation that makes everyday social situations feel overwhelming. That disconnect between how you appear and what you're actually going through can be incredibly isolating. As one survivor put it, quote, "Having a brain injury is like going into this world on your own. You're trapped in a bubble that you can't explain to someone. I don't need people to understand me, I just need them to respect me." This quote about being trapped in a bubble is something we've heard many times from survivors. It speaks to the difficulty of explaining a complex, fluctuating condition and the emotional burden of constantly trying to justify or prove that you're struggling. Loud social settings can also be overstimulating, which can in turn limit the types of social interactions a TBI survivor can attend or engage with. Similarly, chronic pain, fatigue, and difficulty expressing thoughts and feelings can also act as a barrier to social interaction. This is especially stark for a person that was extremely social beforehand. Survivors are often asking themselves questions like, am I still me? Will I ever return to who I was? And is this permanent? As providers, it's crucial that we recognize this emotional weight. Even in sessions focused on function, range of motion, or cognition, we need to still be attuned to the silent emotional burden our patients may be carrying. And we need to create space to name it, normalize it, and support it. By encouraging survivors to engage with specialized communities like our own Synapse peer support group, the healthcare system stands a better chance of combating traumatic brain injury on all fronts. Even knowing that people are willing to listen can alleviate the sense of isolation. On a larger scale, we can work to spread awareness about the experiences of TBI survivors and fight for a future where patients, friends, and family have the proper education to support the survivor. Another opportunity for systematically improving treatment lies in the road to recovery. After receiving treatment from a psychiatrist and undergoing rehabilitative therapies, patients can still feel overwhelmed by the process of adjusting to life with a TBI. Consider, for instance, how many young people can struggle with mastering the fundamentals of adult life, from navigating finances to coordinating home maintenance. Survivors report that experiencing a TBI can feel like a reset, or they must relearn these modern survivor skills, both altered or reduced cognitive abilities. Moreover, as these quotes point out, not only does it point out the importance of providing social workers, but it points out the importance of providing them in an accessible manner that recognizes the cognitive challenge that many individuals with TBI can face. Eric, who was mentioned earlier, who faced the stark housing crisis, shared that he often wished that his doctors had shown more personal investment and connection, that sense that the provider truly saw him as a person and not just a case file. Another survivor expressed the enormous gap in support after discharge, saying, quote, "I really needed someone who could have helped me pull the things together after leaving hospital." This underscores the need for multidimensional support systems that go beyond medical follow-up, including practical and emotional support to help survivors navigate services, community resources, and daily life challenges. Richard, who is another participant, echoed this as well, emphasizing that recovery is not only about medical rehabilitation, but also includes recreational support and engagement from various organizations to rebuild a sense of identity and belonging.
And this is where you all come in, as we will list some recommendations that we could think of. So first is the personalized care plans and comprehensive assessment tools. So developing individualized care plans that consider how TBI affects a patient's biological, psychological, and social functioning can significantly improve treatment outcomes. Since no two TBI patients are the same, personalized approaches are essential. Additionally, implementing comprehensive assessment tools can help providers accurately evaluate symptom severity and functional limitation. This information can guide tailored rehabilitation strategies to address each survivor's needs. And next, we thought of advocacy and financial counseling. So, advocating for policy changes to expand insurance coverage for TBI related services is especially important for survivors who may be unable to work. Offering financial counseling services can also help reduce the emotional and logistical burden associated with the cost of treatment and rehabilitation, allowing survivors and their families to focus more fully on recovery. And next is some other more recommendations. So many individuals living with TBI experience impairments in short-term memory, executive function, and time management, making scheduling an appointment adherence especially challenging. At the time of referral or scheduling, ask explicitly whether the patient has cognitive needs or communication preferences. You can build accommodation flags into EMR systems so staff are aware in advance. Given this, a possible solution could be to send email reminders well in advance, text messages, or accommodate the patient's preferred communication system. You can ask the patient their preferred method of communication, as some may need audio over text due to reading difficulties. TBI survivors frequently report sensory sensitivities, particularly to light, sound, and visual clutter. This can result in physical discomfort, disorientation, or even emotional distress during a routine exam. So it is recommended to equip exam rooms with adjustable lighting, dim or indirect, options to turn off overhead fluorescent light, soft or neutral wall colors to reduce overstimulation, and physical accommodations for those with mobility impairments. Additionally, providers can minimize noise disruptions by using quieter spaces when possible and limiting hallway traffic, offering noise-canceling headphones or sunglasses if ambient conditions can't be adjusted, and reduce visual clutter and provide clear signage in plain language. Because TBI survivors often struggle with retaining verbal instructions, navigating systems, and coordinating logistics, discharge and follow-up processes should be simplified and actively supported. You can provide written discharge instructions in large font with bullet points and avoid medical jargon. Include visual aids or diagrams when possible, such as flowcharts that list out the next steps. Ask patients if they would like instructions to be also sent to a caregiver or family member. And when scheduling follow-ups, you can ask about transportation availability and offer flexible appointment times if they rely on others. reconfirm in writing by text and or email, using redundancy as a form of accessibility, not an inconvenience. And for patients needing more assistance, you can offer a warm handoff to social work or care coordination. Many patients are handed long lists of services, including home care agencies, specialists, waiver programs, and left to make sense of it alone. For someone living with a TBI, especially one that affects memory, attention, or executive function, this is nearly impossible. We have heard firsthand how survivors can't even write down their own name, yet they're expected to call dozens of providers and make complex decisions. What they need is navigation, someone to help narrow options, make initial contacts, and follow up. This is especially important for patients without strong family support or digital literacy. Discharge is a vulnerable and pivotal moment. Without structured follow-up and support, survivors fall through the cracks. Social workers are uniquely equipped to bridge this gap. They can assess living situations, coordinate services, advocate for housing or insurance, and most importantly, they can serve as a steady point of human connection in a disjointed system. Including them in discharge planning is not just about paperwork, but it's about saying that we care about, we are thinking about your whole life, not just your injury. Imagine trying to fill out insurance forms, waiver applications, or consent paperwork while in a fog, fatigued, or unable to remember what you just read. For many survivors, the paperwork itself becomes a barrier to care. Trauma-informed and cognitive aware means to simplify the language, to use large fonts and clear steps, and offer assistance when patients are completing forms by asking questions like, do you need help with this? So first, you can offer validation. You can use affirming languages like, I see how that could be frustrating. I hear how much this has changed your life. It makes sense you're grieving who you were before the injury. And avoid phrases like, you're lucky it wasn't worse. Even well-intended statements like this can dismiss the very real internal suffering a patient is experiencing. And next, you can ask about who they were before. So ask questions that invite patients to think about their identity before the injury. So ask questions like, what was your day-to-day life like before this happened? What's something you miss or wish you could still do? What's part of your identity do you feel has been impacted the most? These questions can help patients feel seen beyond their symptoms and offer providers valuable context for care planning. And next, you can involve mental health and peer support early. Make proactive referrals to neuropsychology, counseling, or support groups, not just when a patient shows signs of depression, but also as a standard part of TBI recovery. Normalize emotional support as part of recovery by saying most people going through this benefit from talking to someone because this is hard and you deserve help navigating it. And you can offer emotional sensitivity by ensuring that emotional responses from patients are not interpreted as rudeness or noncompliance, but as signs of distress, grief, or overstimulation. And lastly, you can recognize ripple effect. TBI can strain families and relationships. Partners may not recognize the person they once knew, and survivors may feel ashamed or burdensome. You can ask about relational dynamics by questions like, how are things going at home? Have you had the support you need from people around you? Offer family-inclusive counseling, referrals to TBI family support organizations, or educational materials designed for loved ones. And I'll pass it to Wyatt now.
Thank you, Jessica. Yeah, so nobody is truly prepared to suffer a TBI and will most likely need assistance learning about and connecting to applicable resources. Some resources, I'll go over some of the resources our participants and the contributors to the storybook found helpful. The first one being support groups. In support groups, participants often cover a variety of stages across the recovery journey, and it's a space where participants experiences, observations, and feelings can be validated. The variety of experiences and perspectives provide a wealth of resources that can be applicable to new and returning participants alike. Insurance, medical, legal, and housing resources, to name a few, are often discussed and shared. Participants often have shared experiences and can validate the experiences of others in a world that can feel isolating. There are also safe spaces for socializing, especially for TBI survivors who find their typical social spaces challenging, and where they can learn about advocacy as well. Another one is the TBI identification badge. Individuals with TBI often have difficulties with coordination, speech, processing speed, and regulating emotions, especially in stressful situations. And this ID card is wallet-sized, and it identifies symptoms and challenges TBI survivors face, with the goal of preventing or at least limiting potential misunderstanding with police, EMTs, and others who they might interact with. And also, there's the New York State TBI Medicaid waiver. This is a waiver. It helps helps people with TBIs receive the medical treatment that they need. It also helps with returning to community-based settings or living independently. And it can assist with housing and other relevant support unique to those who have TBI. All right, so what about the care journey? This is, in the slide, this is a visual of the winding care journey with its many loops and turns, and this accurately reflects the path for many survivors. The first step is recognition, or noticing that something is wrong. Many times, the signs and symptoms of TBI and the need for medical care are clear. However, many other times, recognizing a TBI is delayed and complicated. Many survivors don't get recognition until weeks, months, or even years later. Some symptoms may be subtle or misattributed to stress, anxiety, substance abuse, or behavioral changes, complicating the process for patients and medical professionals alike. From there, the patient care trajectory goes to acute care, classification and rehabilitation, involving various medical specialties and types of healthcare professionals. Every patient's injury is different, with their unique set of symptoms and personal circumstances, making acute care especially challenging. Rehabilitation also stands out. While the most rapid improvement often occurs in the first 6 months after acute care concludes, the recovery process is full of setbacks, reassessments, and systematic barriers, especially when the survivors begin reintegrating into independent living, work, or school, and face people and structures that are not particularly understanding or accommodating of the survivor's challenges and differences. This is where we'd like to highlight the blue and orange dashed lines of the chart that demonstrate how individuals can still develop chronic symptoms and need long-term care even after formal rehab. Furthermore, it is not uncommon for individuals to experience re-injury, restarting the journey and reminding us that the journey is not continuous or smooth. As healthcare professionals, we may interact with patients at one point along this path, but we need to understand the entire landscape they're navigating. We must ask, what stage is the person really in? Have they been connected to the next stage? Are they still lost in a loop somewhere behind the scenes? Importantly, this is a good reminder to reference back to the need for holistic care and understanding that each patient's case is individualized for their own situation. This also brings us back to our discussion about identity, understanding where the patient is coming from, how the injury affects their emotional and social foundations and how their emotional and social foundations affect their injury. Understanding this journey helps us provide care that is not just technically sound, but continuously supportive, empathetic, and balances optimism that is realistic to the survivor's circumstances and lived experiences. And we have some, to wrap it up, we have some reflection questions. Here are a handful, and we would just ask that you choose 2 to 3 that you find helpful, and being cognizant of time. We won't necessarily share our reflections here, but hope that you'll take the time to think about it, and maybe even share with others in the future.
Yeah, so to wrap up our conversation, we just wanted to leave off with a final quote from one of our participants, which is that when you have a TBI or brain injury, you don't have those concepts anymore. You don't have executive functioning. It's like looking at the other side of the river, the normal society, but there's no bridge to get there. So with that, we just wanted to leave off with a question for you all, which is how can we be that bridge for patients? Thank you so much for listening to our presentation. And we would also appreciate if everyone can fill out a feedback form in regards to their experience with this presentation. We'd love to hear your thoughts as well. And we're happy to take any questions right now.
Well, thank you all so much. That was really, really great, like very in-depth. And I feel like it kind of brought up some thoughts that we may have not considered when we're caring for our TBI patients. And I actually thought that the communication flag and Epic is like actually a really, really great idea. I don't know if we have something like that at Bellevue or at NYU, but it's a really, really great idea that they should consider. So thank you all so much. That was really, really fantastic.
Yeah, thank you so much. And would it also be okay if we took like a kind of a screenshot picture with a few of y'all, if you don't mind turning on your cameras?
Sure. My glasses on. Oh, hi, Laura. Yeah, so you guys know that the invitation for this lecture series goes out to a bunch of different units and departments within NYU, Bellevue, the other HHC sites, the other NYU sites, so Brooklyn, Long Island. So it's a really big cohort, and obviously more specifically geared to APPs, but we get residents and attending. So it's actually, we thought this was such a cool topic to kind of bring in the summer. So thank you guys all so much for being here with us.
Thank you so much again. I'm actually at, like an NYU student event right now, so sorry for the background noise. But yeah, we really
Oh yeah, no
appreciate
worries.
being able to yeah, and actually, if
Awesome.
y'all would be willing to like accept, we would be more than happy to deliver like free in-person like physical copies of our storybook. We have a whole bunch in storage right now, or like a digitalized copy too, if that's of interest. So
Awesome. Thank you so much. If
thank you.
anybody has any questions, you want to put it in the chat. Shreya Naskar wanted to ask, what motivated you to join the support group and support patients with TBI specifically?
Yeah, so for me specifically, I just started off like as a freshman, just wanting to explore different like pre-medical related clubs, and I just stumbled upon Columbia Synapse without much knowledge about uh too much about like really what it really means to live with a brain injury besides just like generally what a concussion was. But after sitting through a few of the virtual support group meetings, kind of moved by a lot of the testimonials that the participants shared and realized that there really was like a gap in needing awareness and an opportunity to amplify their voices. So we're really grateful again for the opportunity to be able to share with y'all and for y'all to kind of learn a bit more about our participants as well. And if you're interested as well, we would be more than also happy to have y'all sit into one of our peer support groups. We have it weekly on Saturdays from 2 to 3 p.m. virtually. So it's definitely accessible for
Well, thank you everyone so
Okay,
much.
for me.
And oh, anybody? Sorry, Wyatt, go ahead.
No, that's all right. Yeah.
Okay. All right. Well, but thank you guys all for joining, and best of luck to you all in your as you continue on your education there at Columbia.
Thank
Maybe
you.
we'll see you here in around Bellevue and NYU.
Thank you.
Thank
Right,
you.
everyone, take care.
You too.